In the pathophysiology of a brain injury, the swelling is initially caused by cerebral vasodilation, and then this is because the brain now wants a lot of oxygen, and the increase in the cerebral edema contributes to further swelling. And then as this happens, we're actually impeding the ability to perfuse the brain. And so then we end up with what we call an anoxic brain injury, which is a low oxygen level. And then it can only be improved by high oxygen levels. So a common response to head injuries is vomiting and seizure-like activity. Pushing forward, the adult skull allows very little expansion of its contents, and that's because all of the major cranial bones have fused along those fissures. The bleeding inside the skull increases ICP. The bleeding can occur throughout the brain, and then the cerebral perfusion pressure is a measurement of blood flow through the brain, and the difference between MAP, your mean arterial pressure, and ICP is your CPP. So a CPP below 60 will result in cerebral ischemia. And there's a pretty simple math formula we went over when we were going through this in lab. And so if you want, refer to that math formula so that you understand whether or not the brain is actually being perfused in any given situation. So these are the early signs of ICP, or I should say increased ICP. And the early signs are vomiting, headache, altered LOC, seizures. And then as the brain becomes even more hypoxic or ischemic, it's going to go into what we call Cushing's triad. And then we'll have unequal or unreactive pupils, and then posturing. And if you guys remember the posturing, decerebit is the last posturing before we go into basic brain death, decorticate being just before that. Now, when we're talking about bleeds in the cranial vault, we have the epidural hematoma, and this is the accumulation of blood between the skull and the dura mater. So this is actual bleeding that's not actually into the brain, but it is putting significant pressure between the skull and the brain. And again, I want everybody to remember, there's not a lot of room there. So if we add 50 cc's of blood between the dura mater and the skull, something is being compressed. So not only do we have that injury that caused the bleed, but we're going to have an injury because we're putting pressure against tissue that is very delicate. And as that tissue starts to die away, the bleeding will continue unless it's clotted off. And it's just kind of like this compounding spiral of negativity. This is a pretty good picture that shows the dura mater and the hematoma. And like I said, you can see this shift where the bleeding is taking place, and it's taking up space where the brain would normally be. So again, we have the initial injury where something's caused the bleed, and it's putting pressure on the brain tissue. And this brain tissue is being killed off every second that it's had that kind of a pressure against it. So anything that's not immediately crushed is dying off because of hypoxia, because it is clamping down against all of the tiny capillaries that are running through the brain tissue already with that induced pressure. Diving a little bit deeper, no pun intended, is the subdural hematoma, and that's the accumulation of blood underneath the dura mater, but it's still outside the brain. And this occurs mostly in falls or injuries involving a strong deceleration force. And this will show up with fluctuating LOC and then focal neurologic signs. And so the reason that we're talking about this is because that strong deceleration force actually lets the pia mater and the dura mater kind of shift amongst each other in that arachnoid space. And that, if you guys remember the picture, shows where there's a lot of vasculature and there are shear forces there. Again, you can see this is now kind of almost directly against the brain. It's underneath the dura mater, and it's still compressing the brain tissue. So the same kind of injury is going to present. You have somebody with a direct insult, and then we have the increased cranial pressure, and it's killing brain tissue off by the second. Now we get into the deepest part, and this is the intracerebral hematoma, and this is bleeding within the brain tissue itself. And if you guys remember what I was saying, any blood outside of the vasculature is necrotic to tissue, the brain tissue being very highly susceptible to necrosis from being in contact with actual blood. And this is doing every bit the same thing as any of the previous two. And this is bleeding, which is causing tissue crushing anywhere where that bleeding is occurring, and that's killing off these brain cells. The bigger issue here is that because We're not relying on any of the actual like pia matter or the dura matter to kind of contain this bleeding. This will continue to crush into the brain tissue quickly. These patients are going to deteriorate almost immediately, and you will see them go from what looks like a significant TBI to death in minutes. All right, moving into concussions. Concussions happen due to a blow to the head or the face, and this is a mild traumatic brain injury. It results in cerebral dysfunction that usually resolves spontaneously, and 90% of patients who sustain a concussion do not experience a loss of consciousness. But anytime that you have had a loss of consciousness, be that traumatic or say due to asphyxiation, that is also considered a concussion. Signs are confusion, disorientation, retrograde and anterograde amnesia, and it only lasts for a short amount of time, and then they tend to bounce right back into normalcy. When we're talking about signs and symptoms of concussion, we're looking for weakness, dizziness, visual change, nausea, vomiting, ringing in the ears, slurred speech, and the inability to focus. Lack of coordination or delay in motor functions, and then sometimes some inappropriate emotional response or temporary headache or disorientation is considered normal as far as signs and symptoms of concussion. Now we're going to move towards diffuse axonal injuries. And this is associated or very similar to a concussion, but unlike the concussion, it's often associated with a poor prognosis. So this involves stretching, shearing, or tearing of nerve fibers, and this is generally from a very high speed, high energy, where we have, say, a massive amount of force applied to the brain. And you can think of this as kind of probably a direct likelihood to say like a head-on collision at high rates of speed, with or without impacting a steering wheel or any other part of the vehicle. Then we go into a cerebral contusion, and this is where the brain tissue is actually bruised and damaged in a specific area. It's more serious than a concussion. It involves a physical injury to the brain, which causes bigger neurologic deficits. And then there are some mechanisms of injury that cause concussions that will also cause a cerebral contusion. And this is really kind of dependent on the condition of the person who sustained the injury and just how far we got into that MOI, where did we actually increase the likelihood that the damage was more severe. So this is where we go into other brain injuries, and this is where not everything is actually a result of trauma. It can be medical conditions by blood clots, hemorrhages, or again that meningitis where we have an infection of that meninges. So all of these things can be non-traumatic, and they can cause some of the same symptoms as a traumatic brain injury. The big difference here is there's no obvious history of a mechanism of injury or any external evidence of trauma. So if you guys are remembering, my favorite mnemonic, AEIOU tips, right? You guys can kind of get through most of these and try to figure out what's happening with anybody with altered mentation. And if you come up with kind of like no reasonable explanation, this is where we start kind of diving into those darker corners looking at TBIs. Now we're going to move a little bit distal, and we're going to go into spine injuries, and the spine can be injured in several different ways, and dependent on how severe the spinal injury is, we can have a loss of sensation or motor function, which would be paralysis. We're going to try to divide this into a couple of different injuries, and the first is going to be the flexion injury, and that's the forward movement of the head. And again, this is kind of that I'm having a head-on car collision, and you know, the whiplash effect at a significant amount of force. This isn't just your normal everyday my neck muscles are sore whiplash. This is a real amount of force where we have the head kind of whipping on a pendulum, and this can cause some significant injury to the spinal cord in the C-spine and T-spine. We can have vertical compression, and this is transmitted through the vertebrae bodies, and it's directed through the skull, the pelvis of their feet, and it can cause herniation of discs, compression, and fragmentation. And this injury pattern is, say, somebody that's falling and they land on their feet and they send all of the force up through their spinal column, which would cause that kind of compression fracture. Hyperextension. This is usually found in a lot of motorcycle accidents where the back is hyperextended, and it can cause lots of fractures in the vertebrae, and that will cause injury to the ligaments, and then again that swelling around the spinal cord and this can happen anywhere along the spinal tract. The primary spinal cord injury occurs at the moment of impact. A spinal cord concussion is a temporary paralysis or sensory dysfunction that lasts 24 to 48 hours. A contusion is caused by a fracture, a dislocation, or a direct trauma, and this is where we get that swelling. And if this isn't mitigated almost immediately, that's where we get into these lifelong spinal cord injuries, or the paraplegics or quadriplegics. And then we can get all the way into a cord laceration, which is usually when a projectile or a bone enters the spinal canal. And so that could be like a GSW that actually connects with the spinal tract, or somebody who shears a piece of bone and it actually fragments and enters into the spinal tract. We've already kind of covered the secondary spinal cord injury, and that's that swelling or other things that are happening with the inflammatory process, which again is going to cause a massive amount of damage if we get a lot of swelling on the spinal cord. Spinal shock is temporary condition that usually, if we can kind of mitigate the swelling or the other issues that are going on right after the injury, sensory function below the level of the injury is going to be impaired. And based on where we've injured that cord, you can either affect the motor or the sensory portion of the spinal cord, and we may get into that a little bit deeper. Neurogenic shock, you guys have heard me talk about this. This is that line of demarcation or something like that. Neurogenic shock, you guys have heard me talk about in lab, and this is what we're talking about when somebody has say a line of demarcation. This could be completely systemic, but what we're really looking for is that resultant hypotension and hypovolemia, because all of the vasculature has been vasodilated because it's not getting the sensory input from this CNS. There's going to be a decrease in cardiac preload because we just can't get enough of the fluid back up to the pump. There's a decrease in stroke volume and cardiac output because of all of this. And then there's a bradycardia because the nervous system is not telling the body to increase stroke volume or output. The cardiac tissue is relying on its own internal pacemaker at that point. And then hypothermia will set in fairly quickly because as they vasodilate, the body is going to radiate off a lot of heat, and because they will not actually contract again, they're going to continue to radiate off body heat to a point where they actually become hypothermic. It goes without saying, anybody that's unresponsive should be treated as if a spine injury exists. The majority of spine injuries are associated with head injuries, and in this slide, it says provide full immobilization regardless of physical findings, and that's no longer true. We're not practicing the full backboarding. Even the National Registry is saying that it is no longer something that's being tested on. We're only placing C-collars because the Board of Surgeons has shown that there's very little in regards to the outcome that we will get by fully immobilizing a patient. And just giving a patient the ability to immobilize their neck, and they can assist you, or if they're unconscious, there's very little benefit to the actual time that it takes to immobilize them to a backboard. So your MOIs are going to be what suggests your spinal or your head injury, and obviously this is motor vehicle crashes, falls, blunt trauma, hangings, recreational accidents, violence. Anything that you want to call a trauma is going to go into that MOI for a spinal or head injury. You want to avoid any movement that's going to cause further injury, and this again is why we don't backboard that much, because patients who are awake are much more likely to be able to get themselves extricated out of a vehicle without injuring themselves further than you actually doing the work for them. Complications of spinal cord injuries are serious, and depending on where they're at, they can often lead to death and for sure a lifelong disability. So in your primary assessment, obviously anybody with some kind of underlying spinal injury or head injury, we're always going to be doing the life threat management, and that's going to be airway, breathing, and circulation, and it just depends on what you see first, right? So if we have significant bleeding, we're going to control the circulation and then assess airway and breathing. If it's there's no obvious bleed, then we're going to go airway, breathing, circulation. AVPU, right? We want to know what's this level of mentation. This is across the room, and then reevaluate and always look for trends in your patient. And that's, like we said before in the previous lectures, you're always looking to see if your patient's either trending up, which means that something's going right, they're maintaining, which means that you're doing the best you can and they're not going to get any better, or they're degrading. And for the most part, we're looking at what can we do to change what it is that we're treating this patient like. This slide just kind of reiterates what we're talking about. Your general impression is usually correct. This is that across the room, sick or not sick, and then you're going to use the rest of your assessment findings to prove yourself wrong or right. And in unresponsive patients, we're always going to assume that they are sick as sick can be, and then try to remember to gather any of the history that you can by emergency responders, family members, or bystanders that have some kind of helpful information about the history of that event. So when we're dealing with an airway for somebody who we have a suspected C-spine injury or any kind of spinal injury, we're not going to use the head tilt chin lift. We're going to use the modified jaw thrust, which is us hooking our fingers underneath the angle of the jaw, and we're going to lift the jaw up, much like a supraglottic airway does. We're going to try to pull the tongue up away from the back of the airway so that they can effectively ventilate if they have snoring respirations. If you have to, you should always put the head in a inline and neutral presentation. We're obviously going to have a C-collar on them, and then we're going to evaluate their breathing at that point. If they need oxygen, they get oxygen. We want to keep their oxygen values at 90 to 94%. And again, use your simple adjuncts if it's indicated, right? We don't have massive facial trauma. We absolutely can use the NPA. And if they're unconscious, we can use an OPA. And if we need to actually go further down that road where we're going to secure their airway with a supraglottic, then at that point we'll choose whatever device is in your system. But any of that is appropriate if you have somebody that cannot maintain their own airway. Anybody with a significant head injury or a spinal cord injury should obviously be transported as soon as feasibly possible. Most of these patients do not require anything that's going to be intervention-wise on scene. And you're really not doing them any favors by doing anything on scene at that point. It should be get them onto the gurney and get them en route to the place that's going to do them the most justice, which is definitive care. And for the most part, we're talking about something with a trauma suite. We want to be able to see surgeons and have those problems fixed before they become chronic or life-threatening. So just a little reminder, when you're looking at somebody with the uneven pupils, make sure if your patient can answer your questions, don't get duped by this one. Ask them if they have this condition, right? That's anoscoria. You want to know if this is something that they've had for a long time before you overhype that particular patient. If they are unresponsive and you see this, just factor in that there's a TBI there. LOC is always going to be your most reliable sign of a head injury. And so these patients, again, are a load and go, right? We're scooping them up and we're running with these patients. We're looking for signs of confusion, disorientation, anxiety, they're combative, or they just have a degraded or deteriorating mental status altogether. And if they're unconscious and posturing, we know we're really, really down that road. This is your GCS scale, and this is the components that equal 15. And 15 is there's no neurologic disability. Anything that's like, and we can go all the way down as far as a 3. And if you look at just how this is scored, a rock scores a 3. In the world of ALS, it's below 8, gets to have an intubation. So these things are pretty significant. You have to be pretty far down that pathway for you to get to that point. But you guys should probably know how most of this works in regards to actually performing a decent level of response. No trauma would be complete without the DCAP BTLS. And then make sure you're checking for CMS, which is your circulation, your motor, or your sensory problems. If there's an impairment, note the level. Always try to do bilateral. We're looking to see if people are equal on sides because of the way that the spinal cord is actually constructed. They have different pathways from different sides, and you can kind of guesstimate where this injury is coming from. Pain or tenderness when you palpate the spinal area is a warning sign. And I generally instruct people to palpate down the sides of the spinal tract because we're looking to see what hurts this particular patient. And if you're right on top of the actual spinal tract initially, and they say yes, you may deceive yourself. So run down the muscle on either side of the spine, palpating that way, and then if they indicate that there's pain at that particular level, then you're going to palpate that actual spinal tract area. Once you've completed the muscles, then you can run back down the actual spinal tract and see if it elicits any different of a pain response. A couple of big rules that we want to make sure that we're dealing with is do not apply pressure to an open or depressed skull injury. Make sure that you do not get caught into a distracting injury. If the skull injury is distracting you from the other injuries that are a life threat right now, you're not doing your patient any favors. Anticipate and manage any kind of vomiting, so that means have your suction ready, be ready or able to tip your patient. You should be prepared for seizures even though you have no medications that you're able to treat them with, and then transport promptly. You need all hands on deck with this one. This is like, I need an actual partner in the back with me. We're dealing with a lot of things that are going on at the same time, and generally it's going to take one person to manage an airway and the other person to manage the cardiovascular system. In regards to C-collars or cervical collars, these are to provide preliminary partial support. They do not stop movement. You're going to have to remind your patient that this is a gentle reminder for them not to move their head or neck excessively, and they should be applied to any patient who has a possible spinal injury. And then make sure that you actually know how to use this device and you can size it and place it correctly. There's nothing worse than showing up into a trauma bay and then having the inappropriate collar on or it placed inappropriately, which may have caused your patient not only just discomfort, but it could cause them injury. So this is one of those tools that you guys should absolutely know how to use inside and out regardless. This is the tool that you get out of your bag and you understand it no matter what. So we're going to have a little bit of a segue here in helmet removal, and this says that if a helmet fits well and it prevents the patient's head from moving, it should be left on. And I'm going to politely disagree with this. A helmet that's covering the face is not doing you any kind of good. You absolutely cannot come up with a way to secure your patient with a helmet onto a gurney, much less let alone a backboard. So when in doubt, if you can get the helmet off without causing an undue amount of pressure to the neck, you should remove it. I'm going to add in a small video clip of the new types of helmets that have the cheek pads have an emergency removal system on them so that you can actually take the pressure off the face to remove the helmet quickly and easily without compromising their neck.
Motorcycling provides an unrivaled feeling of freedom that has beckoned riders for generations. Unfortunately, there is danger lurking around every corner, and even the most experienced riders can find themselves involved in an accident. In this circumstance, prompt and proper treatment can make the difference between life and death. When a rider is rendered unconscious or has a suspected neck injury, emergency medical personnel often must quickly and safely remove the injured rider's helmet in order to evaluate the rider's condition and render assistance. In this video, we will demonstrate Shoei's exclusive emergency quick release system, which can aid emergency medical personnel in removing an injured rider's helmet more safely and easily. First, check the injured rider for any critical external injuries. If the injured rider is not able to remove his or her own helmet, specific procedures must be followed to ensure a quick and safe removal by the attending emergency medical personnel. 2 people are required to complete this process. One rescuer must securely hold the helmet to prevent any movement, and a second rescuer releases or, if necessary, cuts the chin strap from the helmet. If cutting is required, use safety scissors with rounded ends and carefully cut the chin strap, using caution not to cut the rider with the scissors. Check to see if the helmet is equipped with the EQRS red tabs. While the first rescuer continues to stabilize the helmet, the second rescuer reaches in to hold the red tab. Pull strongly on the red tab to release the snaps holding the cheek pad in place. Pull the cheek pad out through the bottom of the helmet. Repeat the same procedure for the second cheek pad. While one rescuer supports the injured rider's neck and head, the second rescuer slowly and carefully removes the helmet. Pull straight and be careful not to twist or block the injured rider's airway during this removal process.
When we're immobilizing children, again, we're not using backboards anymore, but you may have to immobilize a child from time to time, and we should always be trying to use soft splints or something like that KEDS can, in a pinch, be used as a very small pediatric backboard. But again, the general idea is that we're trying not to put people on backboards anymore, anywhere in the system. And if we are doing that in the case of, say, a pediatric, this is more to protect them from maybe being fearful and panicked and trying to remove themselves from the gurney, whereas they may cause themselves some kind of injury by just trying to fight the transportation and the treatment. So in regards to stuff like trauma, head, neck, and back injuries are very common. It's something that we kind of call our bread and butter in the EMS world because we respond to so many traffic accidents. So get comfortable with learning how to assess this. If you guys have questions about specifics on, say, respiratory patterns that are indicative of a head injury, let's talk about that in lab. If you have more questions, send me an email.